Good afternoon, ladies and gentlemen. It's 12:05, and we had scheduled for a noon start. I was just waiting so that the classes get over and some of our students who had wanted to join us. But since I have a few minutes of opening remarks, I thought we'll get started. So welcome. My name is Adnan Hyder, and I'm the director of the Johns Hopkins International Injury Research Unit. And our unit is hosting this lovely seminar, and we are delighted that all of you could attend. And I know that some of you are now listening to me on the internet through live stream. So welcome to you all, those who could not physically make it, but are listening on the internet. So welcome again. I'm really excited today that we have a seminar dedicated to a critically important topic that our unit has been confronting for many years. That is emergency medical systems, sometimes called trauma care systems, or emergency medicine, or pre-hospital care, or hospital care, and so on. As you can imagine, many different connotations and phraseologies that have been used. But fundamentally, what we want to talk about today is a little bit about EMS systems, and we have a foremost expert in the world with us. I will be introducing him in a few minutes. But first, I wanted to spend a little bit of time reminding you all about our unit and the work that we do. The Johns Hopkins International Injury Research Unit was developed nearly 8 years ago, 9 years ago, in 2008, here at the School of Public Health. But while we are hosted in the Department of International Health, we are indeed a unit that transcends school and divisional borders, and you will see an example of that today. Our mission is really through research, collaboration, and training to provide and explore and implement solutions to the growing burden of injuries and trauma around the world. We are particularly interested not only in just generating information and data, but also making sure that that gets implemented in terms of programs and policies. Now, for those of you who've thought about injury and trauma, you must be aware that this is a very complex problem. So we don't intend to simplify the problem, but rather confront it in its complexity through our strategies of collaboration, research, and training. And just to give you a couple of examples, we are working around the world. This map represents some of the countries where we have current projects going on. Again, the idea is not to work in every country of the world, but to work with meaningful partners. And you will hear about one particular partnership today. We do research, different types of research, intervention studies, economic analyses, policy analyses. We collaborate with different types of organizations, and indeed, as a university unit, we are truly committed to training and capacity development. Let me give you a couple of examples here. We collaborate with non-governmental organizations. You have some listed here. These are important players in the injury trauma field around the world. Very importantly, we collaborate with governments, and these governments are often in low and middle income countries, although we also have collaborations with governments in high income countries. We work very closely with the United Nations systems, particularly the World Health Organization, where both us as a unit as well as many of us individually participate across the board. And we are heavily invested in training. We do lots and lots of workshops, and many of you may have participated in that. For example, we've really done over 100 workshops in the past 5 years, trained over 5,000 people. But we are also using technology, and we are increasingly doing webinars, as we are live streaming today's session as well. In fact, in the past couple of years, we've done 7 or 8 webinars and already have over 100 people from nearly 85 countries participating in those webinars. And of course, here at the School of Public Health and in the Johns Hopkins University, we are teaching both on-campus courses, we teach courses online, we are on OpenCourseware, and now we are very excited that starting in June, we will also be part of the Health Systems Summer Institute, where we have a couple of courses where we are contributing to, and we are really hopeful that that will be another avenue for expanding our training. And of course, we welcome students, postdoctoral fellows, medical and clinical residents who are intending to do research from across the street, and so on. This is part of the bread and butter that we do every day. I think I'd wanted to highlight that, in fact, our unit has been one of the first in the world to develop a free online training program on road safety. And we've already got nearly 1,400 people enrolled in this course. Nearly 350 certificates have been awarded, and many of us, as we travel around the world, we meet colleagues who've actually been certified through this program. It's a wonderful service thanks to funding from Bloomberg Philanthropies that we were able to provide this training. Now, our unit is not limited in terms of its scope. We work on prevention, we work on acute care, we work on rehabilitation. And across the board, we work on a wide variety of both intentional and unintentional injuries. And you can see some of them here. Today, we will limit our conversation to post-injury care, to thinking about emergency medical systems and trauma care. So here are, let me end by showing you some examples. We've been working in Abu Dhabi. This is an example of a high-income country context where we did work developing an injury and poisoning notification system. This system is now part of the government system where every single hospital has to report an injury and trauma case in Abu Dhabi since 2010. We were very happy to be part of this process. In neighboring Oman, my colleagues have just finished a pilot test of a trauma registry in 2 hospitals, and in fact, that trauma registry has now provoked Omani authorities, and they are thinking of how to amend their medical record system to integrate elements of this already in this system. In Qatar, we have just started work with our colleagues at Hamad Medical Corporation looking at occupational trauma. This is a huge issue in the countries of the Middle East, and one of the first times where a unified registry is going to be developed. So a set of examples from the Middle Eastern region. Moving on to a different region in Africa, we've worked on road traffic injury prevention and control in Cameroon. And a lot of this work has been with the ministry there, with the World Health Organization country offices, and trying to understand the burden and seeing how that can be addressed. We've worked in pediatric trauma in South Africa, worked with existing systems and trying to improve them and making sure that their data gets absorbed into policy. And in fact, in Kenya, we are winding down a several-year effort in looking at trauma systems, EMS policies, and in fact, supporting capacity development, both of physicians, but also of EMTs in Kenya. We also do projects that are multi-country, and here's one example of a multi-country project on road safety that we just concluded, where we worked on 10 countries looking at the issue of road safety, both from a preventive aspect and also supporting World Health Organization and other partners think through EMS systems. I want to make sure you understand that we do this through a model of capacity development. And we partner with institutions, and here's an example in Africa where we've had a long-standing collaboration with Makerere University, and we have been working with them, an example of training and capacity development here in building their MPH program to include injury and trauma. And today, you're going to hear a lot more about our 10 years of partnerships with the Aga Khan University in Pakistan, where we have worked very intensively to help and support develop capacity, and you will hear a little bit more about this particular partnership in a few minutes. Of course, we love to publish, and suffice it to say that we've been very successful in promoting in publication jointly with our colleagues from around the world. I hope this contextualizes the talk that we are about to hear. I'm honored and delighted to introduce my friend, my colleague, and my collaborator, Professor Junaid Razzak. Professor Razzak is a professor of emergency medicine at Johns Hopkins School of Medicine in the Department of Emergency Medicine. He directs the mHealth and eHealth training programs there and outreach. But really, what is important for us is to understand that he represents one of the world's leading authorities on EMS in the developing world. Dr. Razzak was trained at Emory and Yale universities here in the US, then went back to Pakistan, initiated work in EMS, and actually established the first academic department of emergency medicine in South Asia and became its founding chair. In addition, along the way, of course, he did a PhD as well in injury epidemiology. We became collaborators thanks to an NIH grant, and over the past 10, 11 years, we've worked very closely together, and it's been very, very rewarding to see the work that he's done, not only in Pakistan, but in the region as a whole, and then we were delighted to welcome him to the Johns Hopkins community. So it's my great pleasure to welcome and introduce Professor Junaid Razzak for our talk today. Thank you.
Thank you, Adnan, for the introduction. And let me formally thank Adnan and IRU for inviting me. Adnan, as mentioned, we've been working for many, many years together, and he has been a friend, a collaborator, and a huge supporter for a lot of activities we did in Pakistan and other places. Also today, I think we have Dr. Amber Mahmood, who was part of the development in Pakistan, and many people from IRU who has been engaged in this activity. Adnan introduced me as world's foremost expert. So it reminds me of a story several years ago when I finished my medical school and I joined the Department of Public Health. I knew I wanted to do emergency medicine, but I had a couple of years in between, and went ahead and talked to one of my first mentors, Steve Luby, who had joined from CDC and come to Karachi to work for a few years. And I said, I want to be an expert in emergency and trauma care in Pakistan. And he gave me 2 papers, and he says, well, read this, and you're an expert now. Because there was hardly anything available at that time. And similarly, another event or incident that happened around the same time, a giant of public health, Jack Bryant, many of you who are senior public health professionals will remember him. And he was the first chair of public health at the Aga Khan University. He had moved from Columbia as a School of Public Health dean. And he and I were talking, and I was a young public health professional, a clinician, and he asked me, what do you think is a major public health issue in Pakistan? And I couldn't think of a smart answer. I said, I think it's lack of hope. And that was about 20 years ago. And since then, I think what we're going to talk about today is the story of, creating something in a difficult environment, giving hope to people who are really in dire circumstances, and also developing a field which didn't have a lot of takers at one point. So the outline of my talk, I'm going to talk about the fundamentals of emergency health system. Many of my colleagues from my Department of Emergency Medicine are here. And for us, it is very easy to think about emergency health system. But surprisingly, in my interactions with many of my public health folks, there's a lot of confusion around it. And it's interesting, even in the World Health Organization, till a few months ago, there was no group responsible for emergency care. And when they talk about emergency in that circumstance, in that environment, they talk about disaster response. So emergency care at the global level, at least at that place, has been ignored. And I thought putting that together and putting it at a structure for people who are relatively new to the system will be useful. Then we're going to talk about the why should public health care about emergency care. We'll briefly touch upon the research of emergency health system. I will talk about our experience in Pakistan and then a study that's part of your folder. And then we'll finish with some summary statements. So this is the scope of emergency care. We have, on one end, we have injuries, trauma, non-communicable disease like acute myocardial infarction, stroke, COPDs, sepsis, maternal health. And these are your typical day-to-day emergency care that any hospital, any department provides today. And then you have disease outbreaks such as Ebola. We have climate change issues like extreme heat and earthquakes, wars and conflicts, and technological disasters. All of these, from individual emergencies to public health emergencies, is what your emergency healthcare system is responsible for. Now, this is your very basic diagram representing what emergency care is. You have what we call bystander, first aid provider, followed by your pre-hospital care provider, or in this country, an ambulance. Patient is transferred to an emergency unit where he gets triaged, sorted out how sick this patient is, resuscitated, and care is provided. And in some cases, the patient may go to the operating theater or go to the ICU or go to the hospital. And somewhere in between, on the transfer side, we might do some triage, recognition, resuscitation. On the other hand, when we look at, and this is your pre-hospital, your primary healthcare level, and your hospital level care system. But when we look deeper into the public health side, what we're talking about is care is provided by family, neighbors, bystanders, sometimes in many countries by what we call community health workers, extenders of healthcare, available within the communities. And those roles, at least in the developing world today, are not very well defined. And one of my fellows, Dr. Shah, who's unfortunately working in the emergency department, is working on community health workers' role in emergency care. Then comes the pre-hospital transport system, getting to the hospital or the primary healthcare facility. Sometimes you bypass that, or you might need an inter-hospital, inter-facility transport. Then you get to a hospital, and from there, you might get discharged or get to definitive care. This is the care as we define as emergency care system for individual patients. Multiple components, everything needs to work together for a good outcome. Now, on top of that is what you build your mass casualty management, your public health emergency response. Unfortunately, what has happened in many parts of the world, and it's going to happen because now we have Ebola and Zika and other things coming through, people will continue to invest in public health emergency response without having a fundamental day-to-day emergency care system. And unless you fix your day-to-day emergency care system, your public health emergency response will not work. In many hospitals in Pakistan, the emergency department on a daily basis will see 2,000, 2,500 patients a day. Now, with that kind of volume, the system is having disaster every day and every minute. I was a resident at Yale, and I wanted to do an elective, and I ended up in a government hospital in Karachi. And in my first hour, I see a patient, a young woman who got gunshot to her abdomen, who was clearly in shock. But the system was so overwhelmed that what I could do in New Haven at that time was not imaginable possible in Karachi at that time. And if you build on that 10 or 10 to 30, 40 such patients, the system will crumble and nobody will get any care. So the important thing is that we need to really think about, in the global health perspective, on the health system side that many of you represent here, to work on developing that day-to-day emergency care system. And that emergency care system requires a few things. It's not as simple as building this. You need, obviously, governance and leadership. The question of healthcare workforce. We have a residency program at Hopkins, a 4-year training program. In my previous department, we have a 5-year residency training program. Before that, you do 1 year of internship, so 6 years. It will take about 200 years for us to have emergency physicians providing healthcare to the frontline hospitals in Pakistan, if we train people for 5 years. So that's not really an option. You don't have that multiplication power in many of these countries. So thinking about what the healthcare workforce issues are in some of these settings. In many parts of the world, healthcare is privatized. So we hear from India, from many other parts of the world where people are coming in to get healthcare because healthcare quality is pretty good. And the private sector is putting a lot of money. And often, before you get care, you have to pay for it. But this is one area where you have to find solutions such that the service is de-linked to payment. And this is a common, easy concept for many in public health and emergency medicine to understand. But I know in many places, people would show up at the door of emergency department and they have to pay first to get care. And obviously, that is not how we want to do this. Importantly, and I put it separately, think about systems to control time. And I'm going to talk more about these things. How do we make sure that we reduce the time? And these are not covered anywhere. There's a little more nuance to that. And finally, the issue of information and communication technology. These 5 pillars have to be thought through before you build a system or while you're building the system. Government can come in and invest a lot of money, but if they don't have a governance structure or healthcare workforce, things will not fly, and similarly other things. So this becomes the focus, the primary thesis of my discussion today of a system-based approach rather than individual based approach. Now, you might go and say, well, let's try and fix a transport system in a city or a country. But unless you have other systems before and after, transport system will not give you the public health outcomes and individual patient outcomes you're looking for. So what are these fundamental pillars that I talked about? Governance and leadership. One of the main issues, I think, today in low, middle income or developing country is the crisis of leadership. We go in, academic institutions such as ours or others will work with funding agencies, and those funding agencies have a grant mechanism that usually 2 years, 3 years, 5 years maximum. Now, leadership development takes a long time. It's a culture change. And hence, long-term engagement and investment in leadership is the key, besides having separate budget line item, Office of Emergency Care, and having govern the emergency care as part of country plans. Similarly, we talked about human resources, the appropriate level of training. Do I need to get emergency medicine as we define in UK or US or Australia in developing countries? My sense is that you can teach skills at in a much shorter time. It is some complex thinking that takes a little while to develop. And can we outsource the complex thinking to a higher level using technology? Similarly, on emergency care financing, we talked about mechanism for fee-for-service. How do you separate the fee-for-service? Romania is a country where emergency care is free. Iran is another country where emergency care is free and all trauma care is taken care of. There is a lot of focus on philanthropic and social investment. And emergency care is interesting, at least in my experience. People who want to have high visibility for their philanthropic investment would like to invest in emergency care because it's highly visible, it has immediate gratification, and there is a greater chance for people to raise funds for that. I talked about system to control time, and I think time to decision making, for example. How does a person or a family whose child is sick makes a decision to go to the hospital? What are the various things that go into this? And one of the most important things, I think, is the trust in the healthcare system. If you don't trust your healthcare system, you may not go there. So, and we often don't talk about this. We create things, but do patients really trust what we are offering them? And finally, this whole information and communication technology piece. One of the biggest change when I first started working in Pakistan was patients showing up, extremely sick patients showing up with no notice. Now here you get maybe 2 minutes, 3 minutes, 10 minutes sometimes. And you realize how important it is when you don't get it. When you don't get a second, a patient shows up and is very, very sick and things don't go right. And these are simple, relatively simple things to think about and find solutions for, but implementing them is a little bit of a bigger challenge. Now moving on, same thing. When you look at uniform access to emergency life-saving, we don't have a simple one-item answer. We could have government subsidy, fee-for-service, which somehow is going through a system so that everybody gets care, and then the whole issue of philanthropy. Why do we care about emergency care? I believe emergency care is one of the highest leverage intervention we have. There's a huge demand for this service. And this is an estimate, obviously. And I think it's a lower estimate based on a few country data. Every year, there are about 1.5 billion visits to the emergency department. So every minute you have 2,500 patients globally using emergency care system. Of these 2,500, approximately 25 die in the emergency department. There's 1% mortality, maybe give and take. So you have a huge number of patients coming to these relatively defined facilities and give you an opportunity to have a huge impact if you try and fix that. Now, if you consider the population of what is 7.5 billion people, you have almost 1.5 billion people getting exposed every year to this system. Also, the interventions that we do have significant public health benefits. And I'll talk more about this. 50% of all years of life lost globally, especially in low and middle income countries, are due to 10 leading emergency conditions. And if today we find a way to reduce the mortality or years of life lost by 10% or 15%, then we have made huge gains on public health side globally. And I think this represents an opportunity that often health system, as I said, has not thought about. And finally, I think there's high visibility, as I said. Politicians love it. They like to make it a huge banner, and they want to put their face on it. So this is a pretty high leverage intervention. Also, I'd like to show you the global burden of disease as it's changing today. You can see the last column, injuries and NCDs are growing in low and middle income countries, and that trend will require more and more focus on emergency care if you want to tackle some of the issues that are going to come across us. And this is a list, and I'm sorry you can't read it. This is Disease Control Priorities, second edition, published several years ago. Now we are working on the third one. And they looked at all the medical interventions that are supposed to be the most cost-effective. And the second most cost-effective after hygiene promotion was emergency medical care, training of volunteer paramedics with lay first responders. I was surprised myself. This is comparing diarrheal disease intervention to HIV/AIDS, Kaposi sarcoma treatment. 6 was management of acute MI using aspirin beta blocker. And 21st was emergency medical care with community volunteers. So you have, among the list of all the interventions available globally, you have some very competitive argument for, even the cost side, for some of these interventions. This is, again, some same publication. Dr. Hyder was involved in this, in addition to a couple of other people. Cost per million, cost per year of life gained, $7 using trained first responders and paramedic responders. And that number goes up, but even if you compare these numbers with what's available out there in public health, these are highly competitive and cost-effective interventions. Burden of disease potentially addressed by pre-hospital emergency care in LMICs. This is a recent publication. Again, diarrheal diseases, infections, ischemic heart disease, cardiovascular diseases. I did a calculation based on some of these, but I removed diabetes, for example, which I think is more of a chronic disease. Yes, we have some acute manifestations, but it's not the primary reason why people die. And what we found, interestingly, is what you see is population for the global level, the PAHO region, EMRO, AFRO, and Euro region, and then you have last 3 columns, which you can't see, unfortunately, the low-income countries, low and middle-income countries, and high-income countries. And what I want you to focus on is, while globally you'll see we have the years of life lost for all diseases, 2 billion years of life lost per year. Of these, 50% are amenable to emergency health services. And if you look at the years of life lost due to emergency conditions per 1,000 population, it's 142. I'd like you to focus on the last 3 rows. In the low-income countries, the years of life lost because of emergency condition is 244 compared to high-income countries is 76. So the disparity between the outcomes caused by diseases that are time-sensitive are 3 times as high in low-income countries if you control for the population. So, and if you look at the top 4 rows, you see in Afro, the African region, the number is 316 compared to, say, Pan American, which is 104, and Euro 108. So you have this huge trend and the focus that needs to be brought in to healthcare system in areas which are lower resource settings. So both your low income and low and middle income countries today need a much more focus than your high income countries. Of course, issues are there as well, a different type. Research in emergency health system. This is a slide taken from the Office of Emergency Care Research at NIH, and it describes various research opportunities in areas of research in emergency care. And as you can see, it goes from subcellular to cellular organ system all the way to population health. and then emergency condition, the acute care and prevention and chronic care. Some of us, or primarily I've worked on the healthcare system side and injury prevention side. And that is the scope of what we are looking at as the research opportunities within emergency care. But if you look at what's coming out of developing countries, only 3% of all research articles published in the top 5 emergency medicine journals in 2015 were published by researchers in LMICs. So while it is a much bigger problem in that part of the world, but the research coming out is obviously non-existent, 3%. And this was a slide that I often present to the Eastern Mediterranean Regional Office of WHO. And we looked at trauma and emergency care publications in 2013, 2014. Total publications were 698,000 on emergency and trauma care. In the time period we're talking about 127. What I want you to focus on is the number of publications from 3 countries in the region, Iran, Iraq, Afghanistan, which are the top academic output in terms of publication on injuries and trauma, 24%, 22%, 14. But the last 2 columns will show you the capacity in the country. While there are a number of publications coming out of Iraq and Afghanistan, only few, 5% and 3% of these publications are led by the local researchers. So, and a lot of that was around war injuries. Of course, there was a lot of upheaval going on, a lot of lessons learned, but the capacity in these countries to do research is extremely limited. And these countries, especially Iraq, had an infrastructure that was formidable before the war. And there are many reasons why we have issues with emergency care. So it's not just the human resource. I think it's a key area. But then you have issues with data collection. We have extremely dynamic, volatile environment and overburdened infrastructure. Trying to do research is a huge problem. In many countries, when I go and talk to people about emergency care, and I ask them, what is your major challenge? It's interesting, the most common challenge people talk about is violence. I would think it's going to be research or training or lack of clinical protocols or lack of drugs or supplies. But most often what you hear is we need to be safe at our workplace. So in a dynamic, volatile, unsafe environment, doing data collection adds a little more complexity. Data analysis isn't a problem because we work on symptom-based diagnosis. The rest of the world works on diagnosis. We have symptom-based, and there's a lot of confounders in the environment. One emergency department and another emergency department just across the street may be very, very different. And I don't have the slide, but we looked at the trauma care outcomes in the city of Karachi between 3 hospitals, which are about 3 miles from each other, 3.5 miles. And there were 300% difference in outcome for the same level of injury severity. And all 3 were teaching hospitals. So, comparing within these cities is hugely difficult. Just imagine how it's going to be comparing globally. We talked about that. And then finally, research ethics. I find it very difficult to talk about issues of privacy and ability to give and obtain consent, even in an environment here in the US at the big Johns Hopkins, let alone in countries that we are talking about. So some of these challenges need to be thought about. A very important problem for us is lack of standardization and definition. Adnan talked about the terms we use for emergency care. So emergency medicine or emergency health services or pre-hospital care. And as a community, we all speak different languages for the same problem. And we have not done, even the field of emergency medicine in many countries is accident emergency medicine, emergency rooms, emergency departments, emergency units. So a lot of that language needs to be thought through, and that's causing lots of problems for us in research challenges. What did we do in Karachi? Karachi, as many of you would know, it's the 3rd largest city in the world, 21, 22 million people. This is where I worked. It was a city campus, but that hospital had lakes in the campus. And it was a private hospital with, but became over time the primary destination for major traumas and a lot of disasters that were happening in the city. There was a year, about 8 months' time, when every third day we would have a bomb blast in the city. And the experience, and this system was functional, so it's not like a community or a city that was war-torn. While we had this low-level conflict going on, the system functioned, and people have had significant experiences in dealing with bad emergencies and large-scale crises. This is the disparities you can see between the care being provided within the same city, very close to each other, private sector, public sector. And I just want to quickly go through how the process of emergency care development happened. 2004, for me, was a start. I sort of started, ended up going to Pakistan. I show up at the emergency department, of course, after a long negotiation. And I show up and say, what do we want to do? And say, well, this is the ER, start seeing patients. So this is how this whole started. We had an emergency room, which was part of the hospital, didn't have any academic recognition. Around the same time, Adnan and I have been working on the Fogarty injury grant. So we brought some money with us to develop some capacity. We started the first undergraduate program in emergency medicine. It remains the top most liked program by the medical students. I was lucky to work as a head of a governor's commission on trauma in the province that I was working in. So had some opportunity to work with policymakers and engaging with politicians. I was asked to, around the same time in 2004 when I went, hospital wanted to expand the emergency department. So they wanted us to design a new emergency department. So that was an experience because residency and your training doesn't prepare you for that. So starting that design process with folks out of Boston was an extremely useful experience. And then we inaugurated a much larger emergency department in 2008. In the same year, we became the first academic department of emergency medicine. I think it was probably the first academic department in developing world at that time. And we were lucky to become the first WHO collaborating center on emergency care. So that gave us an opportunity to sit at the global level in discussions around emergency care. Now, at that time, emergency care was considered in a very narrow sense as trauma care. And we will continue to fight with global policymakers that you need to look at emergency care as much bigger than that. And I think we have been quite successful in the past few years. So WHO Collaborating Center was a great achievement. Then in 2010, the National Board recognized emergency medicine as a primary specialty. I was lucky to become first dean of that and got engaged in national level training. And then had an opportunity to start the first advanced life support ambulance and manage it day-to-day basis. So how do you calculate response time? How do you train people? And how do you retain people? We went from a staff of 3 on my first day to almost 2,000 in 4 years. So we expanded hugely, very rapidly, and sometimes have problems with the speed that things move in academia, because if you work at that speed, and I was chief executive, so I had a lot of authority on getting things done. And that, the ambulance service that I'm going to talk about received the Asian Award for Quality in 2014. So even in that environment, we were able to actually bring it up to a more global level. And now we have this year, we are the first graduate coming out of the emergency medicine program. Several capacity development programs. People came and trained with Adnan at Hopkins, both within my institution and outside. Thousands of people were trained on a short-term training program through various workshops. And I think as we look at the future, and we have been able to train several students, master students, PhD students, peer-reviewed publications which went from, before we started, one publication in 10 years to almost 30 to 40 per year. So pretty active research department and a significant funding. Now after that, something very interesting happened. We were given an opportunity to establish an urban healthcare system. And that urban healthcare system comprised of not just an ambulance service, but a series of small frontline clinics, community health workers that linked the two, as well as telehealth services. So as I mentioned, we actually increased our staffing significantly, and we were able to have services being provided to 1 million patients every day through the community health workers, about 500,000 visits to in the EMS, and one of the largest telemedicine, telehealth setup in the world today, expanded very rapidly. And I think just the population pressure and the vacuum and the need for services helps us expand significantly. So these are some of the activities we did. What I really got engaged more and more with was community engagement. Going and sitting down as an academic emergency physician who see the other end of it, now going into the communities and working with them and understanding what is bothering, what is stopping them from accessing care, and how do we prevent some of these emergencies was an outstanding experience. I'm going to, in the next few slides, talk about, and I know we are coming to the end of it, some of the research work. And I want to raise some of the issues that this research has shown. Now, in your folders, you see this Pakistan National Emergency Department Surveillance Study. This is a special supplement we recently published. And this highlights one of the major surveillance efforts in emergency department research anywhere in the world. So we went and we looked at several hospitals throughout the country. Now, mind, Pakistan is the 5th largest country in the world by population. And you have some of these very large cities. So we went there, we established the surveillance system, and we looked at all comers that are coming through. And in just 4 months, we got almost 300,000 patients registered. So today we have a database that is larger. We understand emergency care being provided at the teaching hospital in those settings much more than most other people would today based on that data. And then we looked at poisoning, falls, drowning, burns, et cetera, on the injury side. And we also looked at patients who were coming in dead, ambulance use, vital signs. We looked at chest pain, traumatic brain injury should be up there on the injury side, and the pediatric diseases. I want to just highlight a couple of findings that we had. Ambulance, this is 2011-12. In 2004, only 5% of patients coming to the hospital were coming by ambulance in the city of Karachi. By 2011-12, it had gone to 35%. Establishing the EMS and working with people had significantly increased it. And what you see is a lot of patients, much more patients with trauma were coming by ambulance services, using ambulances, than those who were not. And this became an opportunity for us to start thinking about trauma care system, because now we are capturing patients in the field, and there's a uniformity, and we can control those EMS services than before, where people were coming from all over the place. Secondly, a very interesting finding, which we have to think about, is cardiopulmonary resuscitation in patients who arrive dead to the emergency department. So if you see among males, CPR is done in much more percentage of patients than among females, and that number is significant. Also, vital signs. We talk about vital signs as vitals. You can't move without them. As you can see, in many of the teaching hospital emergency department, you have most patients not getting vital signs. So some of the things that we take for granted, I think these are simple to fix issues. And here we have oxygen saturation only available to 5% of patients. So how does clinician make a decision in an environment where some of these basic information is lacking? Similarly, we looked at the chest pain patients coming into these hospitals. And again, thousands of patients, less than 1% in younger age group got cardiac enzymes. Overall, only 7% of patients with chest pain would get cardiac enzymes. A lot more number will get EKGs. The number of cardiac enzymes, however, higher among males and females. Males and females are about the same likelihood to getting admitted, but the care process was different. I think partly because for some reason we think that among women, cardiovascular disease is less likely, though that has been proven to be wrong from the emergency medicine perspective. So I just want to share a summary with you, and then we'll have some question answers. What we talked about is a couple of things. System as a whole is the key to success. And we have to understand that some of the system, everything has a much greater impact than individuals. So I was talking to one of my colleagues this morning, and we said, should we fix the triage system in the hospital? Just fixing triage will not solve the problems unless you have the larger system approach. Similarly, just fixing the EMS system will partly solve the problem, but not have a major impact. There are lots of models and clear evidence-based interventions are available. We know what to do, but our issue is implementation. So those of you who are interested in implementation challenge, implementation research, there's a huge opening here, and want to think about that. And I think finally, from health financing perspective, thinking about delinking payment is key to improving services. And I would like you to also focus on some of the discussion we had around the system. And this is a complex-looking system, but things have to be thought through before we go into developing countries and try and give them partial solutions for a little more complex problem. And finally, I see myself as a dreamer, as always been. And I think if we start focusing on, as a healthcare community, on some large targets for emergency care, and such as if immediate life-saving care at home within the 3 minutes time period, where we talk about brain death in many cases, and essential life-saving measures through a trained provider in 30 minutes, and definitive care for emergencies within 3 hours, so 333 vision. I think you have a chance to save significant number of lives. Millions of years of life loss can be prevented if we start focusing on time and the quality as an indicator. I thank you for your attention. Thank you.
Thank you very much, Dr. Razzak. I'm sure you've all understood why, as soon as we heard that Dr. Razzak was coming to Hopkins, we grabbed him to become Senior Technical Advisor to our Unit on Emergency Medical Services. I think you've raised some very important issues, but particularly issues that sometimes we don't talk about. I heard from you about trust. That's not something that we often discuss in our circles. We heard from you about community health workers. Now, community health workers we've talked about in public health for a long time, but we think about immunizations and oral rehydration. But emergency care, wow, that's a new concept. Maybe we should talk about that. We also heard about safety, both safety of not only the population, but safety of the health workers. And you talked about safety in emergency rooms. You've talked about equity and disparity issues. You've talked about capacity development. These are huge themes, and I think we are seeing the resonance of these themes not only in the larger field of public health, but also of EMS. So thank you very much for your discourse. And I think certainly we are very happy here at Hopkins that you've joined us, and I'm sure the Pakistan community is feeling at a loss that you've indeed made the migration. But I think your service is clearly seen by these many years. So I'd like to welcome questions or comments on Dr. Razzak's talk, or in general in the arena of EMS in developing countries. I'll help moderate some of this. So the floor is open, please. We have microphones, by the way. If your voice is loud, that's good, but we are actually live streaming this. So it would be helpful. I don't know, maybe if the mics could get to the participants, if that's easier. I'm going to request maybe somebody on this side, and if somebody could go on that side, that would be helpful. If you can get up, that's great. Otherwise, just raise your hands and we'll get the microphone over to you. Yes, please.
Hi. My name is Ramana, and I was working in Karachi for the past few years at Indus Hospital. So I visited Aman, and I've seen the telehealth ambulance system. And I was interested to learn more about that because you said that ambulance use has increased to 35%. So I was just wondering, is it being studied in terms of who's utilizing the system, and for what types of emergencies, and Also, has the time been reduced in terms of reaching and accessing the facility? So along with this system that's been implemented, are all of these changes being studied, and has anything been published on?
Yeah.
Thank you. I'm going to take 2 or 3 and then request Junaid to respond to them. Yes, let's go on that side.
You mentioned some of the benefits of focusing on emergency medicine and the cost effectiveness of it, but one of the major benefits of it is that it is politically very important, and that's because emergency medicine systems tend to affect people when they're extraordinarily vulnerable. They are very demanding. They're often bleeding right in front of the physicians. They're close to the facilities. They're urban. I'm wondering whether or not this emphasis would continue the disparity between urban and rural areas. It would actually entrench the disparity between urban and rural areas if the focus is going to be on emergency medical services within urban areas in particular. Is that going to be a political problem, or is it something that we're just going to accept on a pathway to getting better emergency medical services in rural areas?
Thank you. And I'll take one more and then we'll...
That is for Etienne. Just to follow up on the question of ambulance use going up to 35%, and for you to comment a little bit about delinking the payments, and if how has that affected how did that contribute to the increased use of ambulances? And what other ideas are out there about delinking payments?
Yeah.
Thank you. So you have 3 questions.
Yeah, thank you. First, the question on EMS and data. There is actually a lot of data. But as you know, in many of these countries, when you're working, a lot of us who are even define ourselves as academic, are busy doing day-to-day operational. You've seen Indus Hospital. Indus, I've been involved in Indus for quite some time. Those of you who, it's a purely free hospital, has no cash counter, and provides services to everybody who comes in. And they have about, I think, 8 or 10 bed emergency room that sees 700 patients a day. So it was, when we were thinking about designing it, we never thought it's going to be so busy. But taking your cue, I think today, those of you who are interested in research, there is data out there, and there is great information available. For example, just to give you some idea, the most common reason for ambulance use in Karachi is to take a patient on ventilator from one hospital to another. So you have these very, very sick patients who end up in somewhere in the hospital. Somebody puts a tube down the throat and put an ET tube, and now there's no ventilator. And in the city of 20 million, there are 200 ventilators. So patients are, so we actually had to create what we call critical transport service and put physicians in there because these patients were too sick to be transferred. But then there's a lot of other information available. The question around urban-rural divide. And that's why what you see is actually my insertion of community health workers, my insertion of transport service, and this whole vision thing that I presented in the end of 3 minutes and 30 minutes. Because I think you're absolutely right that unless we start focusing on those times, we'll be happy with what we have on the urban side, urban areas. In the response time for Karachi, for example, today is on average 7.5 minutes. But if you look at, it depends how you measure it, there are some which are much longer than this. In rural areas, people in India and other places would accept 15, 20, 30 minutes of response time. That needs to be changed. I also think that with today's using technology, we have to think about how do we get telemedicine more engaged so that people have care and help before a physical person is available. So urban-rural divide is an issue which needs to be sorted out, and that keeping the same standard across the board is key. The third question was, remind me what?
Delinking payment.
Right.
Payment.
So it was very interesting. When we started the service, I can share with you the cost per transport was about $40 in EMS. And to reduce the abuse of the service, we put in a charge of $4. So it was not necessarily to make money, but to make sure that we actually don't charge anything. And we were seeing numbers which were about 200 patients a day going through. And then we had a discussion with the board of trustees and said, why are we charging anything? Why don't we just make it free? But then we came to a point, why don't we reduce it to 200? So we went from 200 rupees, from $4 to $2. And in 3 days' time, our service utilization doubled. It was unimaginable that the services are so cost sensitive that you have a little bit of tweaking in the service and people start using it. The other thing we did was, for road traffic injuries and trauma, we made it free. Because you're on the street, you're not going to pay for it. And that also helped us sort of capture that volume. In terms of sustainability, it didn't make a difference, but there came a time where then we started thinking about, we were getting to such high volumes that we said maybe we should now play with the pricing a little bit to control the volume, because we can't handle all of that. But that was a lesson that's why I feel so strongly about, that these markets are extremely price sensitive and they need to be channeled in very appropriately and properly.
That reminds me that in public health, Junaid, we are often taught to make sure that services are not 100% free, because sometimes free services are equated with poor quality services. And in many instances, even if a small centennial charge is really important. So if there are other questions or comments, please use our mic or stand there. And Junaid, I was wondering, you raised the issue of trust. And I recall many years ago reading a paper about women dying in childbirth. In fact, there were 93 women who died within a year, within 5 miles of the largest tertiary care hospital in your city. And the issue was not that there wasn't availability, they were within 5 miles. But the families and the cultures and the societies didn't trust. So did you find these type of experiences?
Yes, in many places, I would ask the families to watch their patients and make sure that they are as involved, because errors do happen. Interestingly, people have done, I didn't do the study, but neonatal mortality in Karachi for children who are born in the hospital is higher than children who are born at home. So it's and the reason is infection, neonatal sepsis is very common, poor hygienic practices. At home, you don't have exposure to all these bugs that you have in the hospital. So there is a reason why people don't trust it. I see often we do interventions that harm patients, and in many of these countries, we don't even realize that.
Yeah. Thank you. Let's take the next couple of questions.
Hi, Dr. Razzak. I'm a physician from India. I worked in a private primary healthcare service, which also was extended to offer pre-hospital transportation and emergency services, in part because our patients were asking for that, because they wanted doctors they knew and trusted. And I was wondering if there is a space for private emergency medical services that you see at all, because you said the volumes are so high and there is so much need. And the second question is challenges that you faced during your expansion of services.
Thank you very much.
Yeah.
Let me take one more,
Yeah, sure.
the lady behind you.
Hi, Dr. Razzak. When I'm also a physician from India, so when I was working in emergency, sometimes we never used to have beds or the required surgeon, so we had to call up nearby hospitals to transport patients, and it would take up a lot of time just to find out, like call, wait online, like call 10 hospitals just to make sure that patient reaches the correct hospital and not keep shopping at different places. Do you think we can, is there any such difficulty you had faced, or what solution can you come up with to make sure that we manage that time instead of just calling around? Or is there like a board where we know where we have enough people, or we have enough time sensitive hospital bed availability, just to make sure that patients don't waste time?
Thank you. Go ahead.
Very practical questions. Just coming to what you're saying, the reason why we have these problems in India and Pakistan, because we have partly privatized health system who likes to select patients that pay well. So you can get a cardiac cath next day, or you can get an orthopedic surgeon to admit the patient next day, because there is financial incentives for doing that. Undifferentiated patient who is septic, an elderly patient who requires a lot of resources, they are sorted out. So and we attempted to establish that service through telemedicine, where I would try and get the information on how many beds do you have in the hospital. And it's interesting, many private hospitals will not share with us how many beds do they have open today. And when you want to have some of these patients transferred, they would want to talk to the family first. You send the family, they pay the money, and then so there is a complex financial incentive for the way system is sorting out itself. I think the related issue on that is, when you are working in the hospital and you're trying to expand some of these services, or when you're working in the EMS and you're trying to expand services, the primary issue is finding the right people. And emergency services are not the place where people would like to spend their time. So this is a rotation where people are sent when somebody senior doesn't like them, so you're sent to the ER to work. And often my family would ask, when would you finish your emergency medicine rotations? Going on for years now. So, those kinds of things I think in many of these countries are happening.
And the question about the role of private services really is, I think, a really fundamental question for the health sector, actually. Yeah. So it's not just EMS, but certainly in EMS, and since you're from India, EMRI is an example, and I know you visited the country many times. And also you have your public sector model 1122 in the Punjab. So some comments around maybe comparison of public versus private in EMS.
Yeah. It's a very slippery slope. The private sector, if you are not controlling them very well, I always worked in private sector in my life, but I know what the limitations of the private sector is. Emergency care is a government business primarily. In Pakistan, and I'm sure about India, 90% or 95% of emergency care is provided by the government hospital, unlike rest of the healthcare system, which is 70% private. So emergency care will remain in domain. When the private sector gets involved, government needs to have a mechanism of monitoring that. So EMRI, for example, government has tried to put monitoring system. In Pakistan, we are trying to get into, with Aman, with the government setup. And what we wanted to do, or what I emphasized was, let's have a third party that we train high enough to measure the quality. So they come in, they look at the quality, and then once we meet those benchmarks, then we get paid for it. So that's the kind of mechanism that needs to be built. Either government does it or they monitor performance.
Great, wonderful. Do I have any remaining question or hands? Oh yes, I'm sorry. There's a blind spot on this side. Please.
Thank you. Well, thank you very much for the presentation. So you mentioned that you've worked a lot with policymakers, both at the global level and at the national level in Pakistan. So I'm wondering, what were some of the strategies you've used to convince them to see emergency care from a health systems perspective? Specifically, strategies are not evidence. I'm very curious about that. Thank you.
It's interesting, and because this is the only area I work in, I find it not too difficult to convince policymakers on the need for emergency care. It's very obvious, And they also realize that if they themselves will get sick, if they have time, they can get the best care in the world anywhere they are. But for emergencies, their families, everybody is at very high risk. So convincing them is less of a challenge. What is more important is to show them exactly how to do it. And if you ask me, what are the good models in low-income countries where there's a successful emergency care system? There are not many. And a lot of it's driven, we so-called experts are driven by our own likes and dislikes. So many emergency experts will go and set up EMS services only. And government will put in resources to it, they will look good, but they will not see the benefit of it without having that system-based approach. So I think the challenge is for us to go in, perhaps with 3 or 5 or 10 clear strategies to the policymakers, say, if you do these, then this is the outcome. And we should be looking for that information.
Okay, next thing.
Yes, please.
Thank you very much for that presentation. I'm Imelda from Uganda, which is one of the low-resource countries. When you were sharing, there was something you said, something about ethics issues, research as far as emergency care. Please highlight more about some of the common ethics issues and what strategies, what has been done in order to overcome them when you are conducting research in emergency care setting. And then the other thing, in low-resource settings, at times when patients are brought, there's a challenge of under-table payments. I don't know whether your services tend to provide, the public services tend to provide free services, or when the patients get there, even in the emergency care setting where they have to pay, or whether you also do experience those kind of problems of under-table payments when patients come in.
Thank you.
Well, I'm glad.
Both good questions.
Concepts are are coming out. The whole issue of underhand payments. We naively, I didn't think it would happen, but we soon realized that there are some hospitals who thrive on taking patients who are already sort of sorted out, and they would like to take some certain types of patients. So there was a risk that our frontline doctors and nurses, both in EMS and in the hospital, would get somehow influenced through money to make decisions on transferring patients to certain areas. And what we started doing was, on the hospital side, we said that the transfer decision will be made by a group of physicians and nurses, and the destination hospital decision will be made by some other group. And every transfer that would happen is going to be monitored on a daily basis, because we were getting some of that coming through, and underhand payment was an issue. I think on the broader ethics research, so this is the ethical issue, the practice of ethics of practice issue. On the research ethics side, I think the fundamental challenge was when we talk about informed consent, and we want all these big forms to become finished and have this discussion and making sure the patients understand and sign things, that often doesn't work. But at the same time, we want to make sure that we do research in these settings, because we want to improve things. So for really sick patients who require resuscitation, there are other ways around it, where you can get community consent, where you engage community beforehand and you go in and do that. But for a lot of patients who are coming in quite sick, but they are not dying right now, for them it is a challenge. And I think institutions and us have to really think about how do we bridge that gap. I don't have a good answer, because I think if you apply today's principles, then in many places research will become very difficult.
I think this also raises the challenge that maybe documenting some of those would be important. And I think your question is an important one, that maybe we have the experiences of this injury surveillance system. We faced many ethics issues, and I think documenting them would help colleagues in Uganda, for example, see, oh, that's what they faced in Pakistan. Maybe they can learn from some of the strategies. So I think it's been a wonderful discussion. I'm going to try, and since it's nearly 1:15, bring all of this to a close. I think what you've seen today is an example of several lessons and principles in public health. First is obviously the capacity of the public health to be a discipline which is not just in prevention, but public health is about caring about the health of the public, and therefore, in this instance, acute care and the notion of building emergency medical systems. I think secondly, here at the Johns Hopkins School of Public Health, obviously we are so interested in working in a multidisciplinary fashion, and so having clinicians, emergency medicine docs, economists, ethicists all working together to confront these issues is hugely important. I want to acknowledge the fact that what Dr. Razzak presented right at the end, and the special issue you have in your folders, is thanks to the support of the National Institutes of Health, the Fogarty International Center, and they have been superb at supporting this Hopkins Aga Khan University sort of US-Pakistan collaboration for the past decade, and we are grateful for that support and hope that these types of publications and interactions can assist many of us. I want to thank all of you for coming today. I also want to thank those of you who are listening to us on the internet live streams. I hope this was worth the time and effort. Certainly on behalf of the International Injury Research Unit, we'd like to welcome all of you again. Thank you for your participation, and we look forward to many more such seminars being organized with many of our own colleagues like Dr. Razzak, but also other colleagues from other institutions. I want to acknowledge the support of the Department of International Health and the Health Systems Program in organizing this seminar, and thank you, Dr. Razzak, for giving us the time and the opportunity to hear about your work. I'd like to welcome all of you for a small reception just outside in the gallery, and to spend more time with our speaker today. Thank you very much.
Thank you.